that there's two reasons why you might want to use a combination therapy with ibrutinib. One is this peripheral lymphocytosis. We still don't yet know much about whether it has any effect on patients, whether it's immunosuppressive, whether it, what are the long-term effects of the lymphocytosis. So one reason is to eliminate that peripheral lymphocytosis. Again, though, we don't really know that that is necessary. The second reason is that most of the responses we see in the relapse setting with ibrutinib are partial responses. And with chemoimmunotherapy and with our other therapies for CLL, we know that the deeper the response that is achieved, the longer the duration of response. We don't yet know whether this is true with the kinase inhibitors, but it is true with our other agents, so that's why people tend to think that it might be true. So the other reason for a combination is to potentially increase the percentage of patients who are going to have a complete response. The attractive agents are ones that also are pretty well tolerated, in my opinion, because we are dealing with an older group of patients, and many of these studies are in relapse disease, so it's people who have likely had chemoimmunotherapy previously. So things like antibody therapies, which are generally well tolerated, are very attractive. Lenalidomide is an immunomodulatory drug and potentially will have some synergy with ibrutinib. And then the chemotherapy and chemoimmunotherapy combinations are pretty reasonable, just given the success of these drugs, even in relapse disease, and the potential for improvement of that with the addition of ibrutinib.